Welcome to our video on juvenile idiopathic arthritis. Let's get started. Here is a list of topics we'll be discussing for juvenile idiopathic arthritis. Let's start with talking about some general information. Juvenile idiopathic arthritis is the most common chronic rheumatic disease of childhood that manifests before the age of 16. It usually affects girls more than boys. It has an idiopathic etiology, although an immunological link with various HLA associations has been described. The disease is considered multifactorial, involving genetic and environmental factors. An autoimmune mechanism causes inflammation of the synovium with infiltration of inflammatory cells that can eventually result in decreased or function loss of the affected joint. Juvenile idiopathic arthritis presents as joint pain, stiffness, swelling, and erythema. Generalized fatigue and fever are often present. Patients can also present with a rash, and hepatosplenomegaly can be found in some patients. Some types are associated with anterior uveitis, in which case patients present with blurry, dry, painful red eyes and photophobia. Complications of JIA include the development of macrophage activation syndrome, a rare life-threatening complication of systemic JIA. We discuss MAS later in this lecture. Blindness and glaucoma can occur as complication of anterior uveitis. Articular complications include leg length discrepancy, limited joint mobility, joint destruction, and decreased growth. Here is an image of anterior uveitis. Anterior uveitis is an autoimmune inflammation of iris and ciliary muscle. The conjunctival vessels of the eye appear engorged, especially at the edge of the cornea, referred to as ciliary flush. Also, the pupil can sometimes be irregularly shaped like we see in this image here. Alright, let's discuss the classification of JIA. We're going to focus on oligoarticular JIA, seronegative polyarticular JIA, seropositive polyarticular JIA, and systemic JIA. After that, we'll discuss other types briefly. First, let's start with oligoarticular JIA. It's defined as arthritis affecting less than 4 joints in the first 6 months of the disease. It is also called polyarthritis. It's the most common form and affects girls more than boys, with a peak incidence of 2 to 4 years. Here is another image by Ambos. Let's take a look at this image depicting different types of JIA. The first image represents a girl with oligoarthritis JIA. Patients have asymmetrical joint involvement, mostly affecting weight-bearing joints such as the knees and ankles. The hips, though, are rarely involved. High-yield extra-articular manifestation associated with oligoarthritis JIA is chronic anterior uveitis. Anterior uveitis can involve the iris only when it is known as iritis, but can also extend to ciliary body, and this is known as iridocyclitis. Lab results will show increased ESR, positive ANA, and negative rheumatoid factor. An ophthalmological exam using slit lamp is needed to diagnose the uveitis. Management of oligoarthritis JIA includes NSAIDs such as ibuprofen, intra-articular steroids, as well as steroid eye drops to treat the uveitis. Disease-modifying anti-rheumatic drugs such as methotrexate may also be used. Alright, let's discuss polyarticular JIA. Polyarticular JIA can be further classified into seronegative and seropositive types based on the presence of rheumatic factor antibodies. In this type of arthritis, more than 5 joints are involved in the first 6 months of the disease. Let's first cover seronegative polyarticular JIA. In this type, girls are more affected than boys, and the disease has a bimodal distribution peaking at 2 to 4 years and 6 to 12 years. Let's take a look at this image again. The second image represents a girl with seronegative polyarticular JIA. Joint involvement in this type can be symmetrical or asymmetrical, and small and large joints may be affected, especially the metacarpal phalangeal joints, the wrist, temporomandibular joint, and cervical spine. Seronegative polyarticular JIA is also associated with anterior uveitis. Lab tests will show an increased ESR, positive ANA, and negative rheumatoid factor, and a slit lamp is needed for the diagnosis of uveitis. It's managed with NSAIDs and disease-modifying anti-rheumatic drugs, such as methotrexate. Next, seropositive polyarticular JIA. Similarly, girls are affected more than boys. The disease most commonly manifests during late childhood to adolescence. Taking a look at this image again, the last image represents a girl with seropositive polyarticular JIA. In this type, joints are symmetrically involved and smaller joints such as the interphalangeal joints are commonly affected. Large joints such as knees and ankles may also be affected. It's important to note that seropositive polyarticular JIA is not associated with anterior uveitis like the other two types we just discussed. Instead, subcutaneous nodules called rheumatic nodules on the extensor surfaces of elbows and the Achilles tendon can be present. Lab tests will show an increased ESR and positive rheumatoid factor. Similar to the seronegative type, it's managed with NSAIDs and DMARDs such as methotrexate. All right, next is systemic JIA. In this type, arthritis is accompanied by intermittent fever that lasts for 2 weeks or more, plus at least one of the extra articular manifestations associated with this disease. We will discuss those shortly. Systemic JIA is also called still disease. It affects girls and boys equally, and its peak incidence is at 2 to 4 years. Here's an image representing a child with systemic JIA. Patients present with arthritis that affects 2 or more joints. Extra articular manifestations include salmon-colored rash, generalized lymphadenopathy, hepatosplenomegaly, and serositis. Laboratory results will show anemia, leukocytosis, and thrombocytosis. A known complication associated with this disease is macrophage activation syndrome. It's a rare and life-threatening complication of hyperinflammatory state related to an uncontrolled activation of T lymphocytes and macrophages, which results in hyperferritinemia, thrombocytopenia, elevated transaminases, and low fibrinogen. Lab tests will show an increased ESR and negative rheumatoid factor. Typically, these patients are negative for autoantibodies. Systemic JIA is managed with NSAIDs, steroids, and IL-1 and IL-6 inhibitors such as tocilizumab. Now let's discuss other less common types briefly. Other types of JIA include psoriatic and enthesitis-related JIA. In psoriatic JIA, joint involvement is asymmetrical, and patients have associated psoriasis as well as anterior uveitis. This type also affects more girls than boys. In enthesitis-related JIA, joint involvement is asymmetrical and particularly involves the knee and ankle. Patients have enthesitis, which is the inflammation of the tendons and ligaments, specifically at the point of attachment to the bone. Enthesitis-related JIA is also associated with anterior uveitis and inflammatory bowel disease. All right, let's pause this video and take a moment to consider this question. A 2-year-old girl is brought to the physician due to recurrent episodes of pain and swelling in her right knee and ankle for 3 months. Her parents also notice her activity level has decreased and she appears tired more frequently. She attends daycare and has not had any trauma. Joint examination reveals tenderness, mild swelling, and erythema of the right knee and ankle joints. The rest of the examination is normal. Laboratory tests show an elevated ESR, positive ANA, and negative rheumatoid factor. So what is the most likely diagnosis of this patient? So this is a 2-year-old girl presenting with recurrent episodes of pain and swelling in her right knee and ankle, as well as tiredness for 3 months. Laboratory results reveal elevated inflammatory markers such as ESR. Chronic arthritis in a patient less than 16 years old is highly suggestive of juvenile idiopathic arthritis. The asymmetrical distribution of major joints such as the knee and ankle joints, the positive ANA, and the negative rheumatoid factor all support the diagnosis of oligoarthritis subtype of JIA. Oligoarthritis, JIA, affects less than 4 joints in the first 6 months of the disease, and girls are more commonly affected than boys. Let's discuss the general diagnostic approach. To be able to meet the diagnostic criteria, the disease onset has to be before the age of 16, and the arthritis must last for more than 6 weeks. Laboratory tests for inflammatory markers, CBC, and autoantibodies should be performed. Ophthalmological examination with a slit lamp is required to test and screen for anterior uveitis. It's recommended every 3 months in high-risk patients and every 12 months for everyone else. A patient is considered to be high risk if they are 6 years or younger at the age of disease onset, if they're ANA positive, and if they've had the disease for 4 years or less. NSAIDs and intra-articular steroids are considered first-line management for patients with JIA. Medications like the DMARDs, systemic glucocorticoids, and biological agents such as tocilizumab and IL-6 inhibitor are considered second-line. Supportive treatment with regular exercise is important to improve mobility. Surgery can be used to correct limb length discrepancy, and orthotics can assist with mobility. Note that slit lamp exams should be performed every 1 to 3 months to monitor response to treatment in patients with anterior uveitis. Juvenile idiopathic arthritis mostly resolves by puberty. Factors associated with poor prognosis include positive family history of the disease, early disease onset as it is typically indicative of a higher level of impairment, a higher number of affected joints at the onset of disease, and being rheumatoid factor positive and anti-CCP antibodies positive. A 10-year-old girl is brought to the physician by her parents due to recurrent episodes of fever and joint pain. She has had pain in her knees, her hands, and her ankles bilaterally for the past 4 months. Her parents have associated it with growing pains, but the pain has not improved. Physical exam reveals tenderness, swelling, and erythema involving the metacarpophalangeal joints, knees, and ankles bilaterally. Subcutaneous nodules can be seen in the extensor surfaces of both elbows. Laboratory evaluations show an ESR of 50. On further evaluation, which of the following will likely be present in this patient? A. Chronic anterior uveitis. B. Generalized lymphadenopathy. C. Positive rheumatoid factor. Or D. Hepatosplenomegaly. All right, so this is a 10-year-old patient presenting with arthritis for 4 months. Her hands, knees, and ankles are involved bilaterally, and they are tender, swollen, and erythematous on physical exam. The ESR is also elevated. Chronic arthritis and fever manifesting in patients less than 16 years make juvenile idiopathic arthritis the most likely diagnosis. Her age, the symmetrical involvement of joint, as well as the subcutaneous nodules on the extensor surfaces of both elbows, make seropositive polyarticular JIA the most likely diagnosis. Patients with seropositive polyarticular JIA are typically positive for rheumatoid factor, so the correct choice is option C. Recall that in seropositive polyarticular JIA, joints are symmetrically involved and smaller joints, such as the interphalangeal joints, are commonly affected, like we see in our patient. Large joints, such as knees and ankles, may also be affected. Also, patients may have subcutaneous nodules on the extensor surfaces of elbows and the Achilles tendon. Again, our patient has all of these classic features. So let's see why the other options are incorrect. Option A is incorrect because chronic anterior uveitis is not associated with seropositive polyarticular JIA. Instead, it's most commonly associated with oligoarthritis and seronegative polyarticular JIA, among others. Option B and D are incorrect because patients with systemic JIA or Still's disease present with generalized lymphadenopathy and hepatosplenomegaly, not patients with seropositive polyarticular JIA. So again, C, positive rheumatoid factor, is the correct answer. This concludes our section.